Hello and welcome to another edition of Cardiac Imaging Agora. In this session, I have the pleasure of introducing actually a very good friend. I've known Dr. Menon since 1992. We trained together. We've been, I think, along the journey of medicine all for the past 28 years plus now. Venu knows about myocardial infarction and the complications of myocardial infarction more than probably anybody in the universe. He's the director of our coronary care unit. He's also the director of our cardiovascular fellowship program. Venu is going to talk to us today about some issues with management of post-MI ventricular septal rupture with some focus on imaging. Venu, good morning.
Hey, morning, Wild. Thanks for inviting me on this program. This is just such a terrific imaging program that I said I'd love to be part of it. And so I'm glad you have me on. So do you want me to go ahead and talk a little bit?
Yes, sir.
All right. So what I thought I'd do was talk a little bit about imaging of ventricular septal rupture. And the reason I did this was I know in your group of talks, you've talked a lot about CT and MRI and the newer modern modalities, but bedside echo is still a really important critical tool in the management of acute patients who are really ill. So let me just run you through an example. Here's a patient we saw recently, comes in, short of breath, in pulmonary edema, hypotensive. Here's the presenting EKG, and you can see the patient is very tachycardic, in sinus rhythm, but there's ST elevation in the inferior leads. And along with that, our Q waves are in the inferior leads too. So you suspect there's a subacute inferior wall myocardial infarction going on with this presentation. Here's a chest X-ray, and you can see the chest X-ray shows bilateral pulmonary edema, and you can appreciate why this patient is in trouble. And so the easiest thing to do is to take this patient to the cath lab and try to identify the infarct artery and open it out. But I think you should also ask the question while you're preparing to do that, why is this patient in so much pulmonary edema and in such trouble with a limited inferior wall myocardial infarction? And so you get the bedside echo, and you can take a look at this first image. It's a nice parasternal image of a ventricle with pretty preserved LV function. I don't see any significant regional wall motion abnormality, and the aortic and mitral valves look pretty good. Put some color on it, and we know the limitations of color on the bedside because of the decreased frame rate in the setting of increased heart rate, a patient being intubated. But at least here, we don't appreciate any severe mitral regurgitation or any eccentric jets that would make us question the integrity of the mitral valve apparatus. So then we focus on the right ventricle here, and you can see that although this is an inferior wall infarction, the right ventricle in size looks pretty good, and the RV function looks very well preserved, and we still don't have an understanding for why our patient is in so much trouble. So we continue with the bedside echo and do a nice short axis view, and you can appreciate on the short axis view a good wall motion abnormality between 6 o'clock and 9 o'clock on the short axis images, consistent with what you would think is the inferior wall myocardial infarction we're seeing on the EKG. When you go to the subcostal view, again, the RV function looks pretty good. LV function looks pretty good. But then you start suspecting something's going on here in the basal septum between the territories of the right coronary artery and the LAD. And then you end up putting color, and voila, the color shows a very large ventricular septal defect that's complicating this inferior wall myocardial infarction, accounting for this patient's presentation. And now the diagnosis completely changes to a percutaneous management of a right coronary infarct to surgical management of a ventricular septal rupture. So with that background, I wanted to talk a little bit about ventricular septal rupture and mechanical complications, and then go on to give some caveats about this as a critical care tool. The really good news is that the rates of mechanical complications have decreased over time. This is a historical slide, but you can see on the left, as we've improved with opening up the artery in a timely fashion with primary PCI, which opens up the artery about 90–95% of the time, the likelihood of mechanical complications is extraordinarily low. This is a little important in the current era because what we've seen in the current COVID pandemic is that the rates of MI have actually decreased because we think people are staying at home and delayed presentation has actually increased. So we are actually seeing an increased risk of mechanical complications in this setting. So I want your viewership to be aware, to be even more alert now for mechanical complications than ever before. In the shock trial, when we looked at patients with LV shock, we excluded patients who had a non-predominant LV cause of shock. So we created a very large registry. And you can see in that registry, a significant portion of patients had a mechanical complication like a ventricular septal rupture, a free wall rupture, or significant mitral regurgitation, either from acute severe ischemic MR or from papillary muscle dysfunction. So this is important to keep in mind. I really like this cartoon. This is a small postmortem paper by Becker and colleagues who looked at the pathology of rupture in the postmortem state, and they divided rupture into 3 significant groups, and it can apply to any mechanical complication that we see. Like in the first case, type 1 rupture is an early slit-like rupture, usually between a hyperdynamic zone and a small hypokinetic zone, which causes a shear and a tear of the myocardium or the ventricular septum. And we call that a type 1 rupture, and that usually presents very early on in the first 20–24 hours of a myocardial infarction. Sometimes we see it even on presentation. In contrast, in type 3 infarction, what you see is gradual expansion of an infarction over time, ventricular dilatation, and then at the very tip of that aneurysm-like dilatation of the ventricle, the myocardium erodes and results in a pseudoaneurysm or a ventricular septal rupture, whatever the case might be, depending on the wall involved. And then finally, in type 2 rupture, this is most seen in posterior infarcts. You see a localized erosion of the infarcted myocardium. So what I thought I would do for your viewers is give you visual examples of each of these kind of ruptures so that they can think this through in your mind. So that first case I showed you was a classic type 1 rupture, but let me show you some other examples of the same. Here, you can clearly see this is a papillary muscle rupture. The LV function appears hyperdynamic, but what you see is a significant tear of the papillary muscle head. The wall motion abnormality is likely very small in this situation, but you're having an inferior or a circumflex dominant artery infarct that's necrosing a small head of the papillary muscle, causing this avulsion and this acute severe MR that would result in this situation. And then on the right, I showed you the typical type 1 rupture in the earlier slide, where between the PDA distribution and the LAD distribution, you can see there's a significant stretch as because of the hyperkinetic LAD zone and the akinetic RCA zone causing this tear and rupture. So that's type 1 rupture. Remember, I told you type 2 rupture is usually seen as an erosion of the posterior wall. So let me show you an example of a type 2 rupture. Here you can see a nice 2-chamber view of the echo, and you can see there's a complete, like a punched out lesion of the entire myocardium. Now this can be sometimes in the infero-posterior wall and can extend and be a pseudoaneurysm, and sometimes can present like a ventricular septal rupture in the inferior posterior aspect of the ventricular septum. Now what about type 3 rupture? Let's take an example of that. Waiting for my next slide. And here, what you can see on the top left is what we see every day, likely a late presenting LAD infarct or a non-reperfused LAD infarct. And you can see there's a large wall motion abnormality in that apex. And I think what you would do next is either put contrast or really look for an LV apical thrombus, because this person is at risk to develop an LV thrombus and embolization. As you look on the right, you see that the contour of the myocardium is not very clear. And in the anterolateral aspect, you wonder whether you can see the complete wall. And I would submit to you, in a busy situation, you may disregard this and still continue to believe this is just an uncomplicated LAD infarct. When you look a little closer in the bottom left, you can actually see a mobile density, and this density is continuous with the apical wall, and this does not represent a thrombus. You start suspecting whether this is a true pseudoaneurysm because the myocardium has eroded in this area. And I confirm that for you in the bottom right, where you can actually see that this is indeed an erosion and actually a pseudoaneurysm resulting from a myocardial infarction that has ruptured into the pericardial cavity. So a big difference between how you would manage this case on the top left versus what you actually have on the bottom right, which is now a surgical condition. And so the role of echocardiography in acute critical care, cardiac critical care, should not be underestimated. And I would encourage all the young listeners in the room to really hone in their echo skills, because it's going to make you do the right thing nearly all the time in these very, very hemodynamically unstable patients. Sometimes the echo is useful in a case like this. So here we see a ventricular septal rupture, but what we see is it's not just a rupture, it's a complete dissection of the interventricular septum by this infarction. And the whole ventricular septum in this LAD infarct is dissected and has then ruptured. Now, you and I, while are fortunate to be in a place where we have some of the best surgeons in the world and we do the most aggressive surgery, but I will submit to you that even in the best of surgical hands, to send this person to surgery to try to repair this ventricular septal defect is close to impossible. And, you know, just to even recognize this is very, very important. Sometimes when we have cases like that, we now shift to using transcatheter devices, either in a palliative fashion or with a hope to try to buy ourselves some time and bridge the patients to definitive repair. So that's another unique use of echocardiography. Here, what we're doing in the cath lab is using a TEE to guide our interventionalists to go across the septum, put a wire across this ventricular septal rupture, rail it from the right and left side, and then close it with an Amplatzer-like device to try to at least decrease the degree of ventricular septal rupture and buy ourselves some time. So you can see we've put an apical Amplatzer here in this situation with a reduction in the ventricular septal defect, at least providing partial relief for a brief period of time. We wrote this article, and I wanted to summarize because we didn't have that much time, with 2 slides about how we think about ventricular septal rupture in the current era. I think you first want to make sure, is a ventricular septal rupture in a patient presenting with shock, or is a ventricular septal rupture in a patient with stable hemodynamics? Because in patients with shock with ventricular septal rupture, the mortality rate with surgery, even in the best places, is 80–85% and not of that. So when we see a patient with shock with ventricular septal rupture, we rarely consider early surgical intervention in that case, because we have found that to be extremely challenging even in the best clinical situation. So in that situation, we tend to either go for palliative care. If this is a 90-year-old patient on dialysis with a stroke, we know that doing surgery is not going to be an option. I think not to invest too much in both intellectually in terms of devices, and instead comfort the family and reassure them and provide comfort is what is needed in that situation. But in other patients, we perform a bridge with all of the supportive devices that we have now, and we temporize the patient, try to preserve end organ function, and make a decision whether we should delay and do a primary surgical repair or put some sort of a catheter device and then bridge to surgery, or we decide whether we can consider something like a total artificial heart or primary heart transplantation by keeping them on a list. Like in this last case, this ventricular septum was too difficult to repair. So we actually listed the patient for transplant, and the patient went for a primary cardiac transplant. On the other hand, with stable hemodynamics, if you have a non-surgical candidate, like an elderly patient or patient with multiple comorbidities, we do try a catheter intervention, or we go with conservative management and a natural history of a ventricular septal rupture. While the literature suggests that some people will survive over a few months, most people will succumb to the disease in the weeks ahead. For those who are a surgical candidate, we need to consider early or delayed surgical repair. With early surgical repair, the benefit is that you prevent unexpected hemodynamic deterioration, and so you can get a good surgical repair early. And in delayed surgical repair, you're allowing time for the tissue to heal and for planning of the surgical procedure. And whether you choose one or the other, I think really depends on consultation with an expert surgeon who you know can trust to give you the right decision as to which way to go. This is our approach to cardiogenic shock. When we have someone with shock, like in the cases that we showed you, we decide whether we can help the patient or not, and then we decide whether the management is futile or not. If it's futile, we stop right there. If it's not futile, we put them on support. The ones who improve, and we wean. The others, we do definitive therapy. And if we can't wean them, we put them on palliative care. So having palliative care in the ICU is very important for the patients who we cannot help, because taking care of people who we cannot help, to make sure that as they pass away, we provide all the comfort that is required, is just as important as taking care of them. So that was a little vignette, and I hope it was useful for your audience. While that's what we have for you today.
Thank you so much, Venu. So I have, this is fantastic overview, especially using a clinical case, using the echocardiographic tools, and then giving us some management advice. So, we all work with, you trained probably more fellows than most people have trained in more than a lifetime. One of the magical wands or magic wands we have as fellows is that echocardiographic ultrasound machine. But it has to be appropriately used, as you said. And one of the small advice I give to young fellows is, if you're dealing with an acute complication or acute situation in the cardiac ICU, the best views to start with are the subcostal views, because they give you views into something that you can do something about beyond LV function or RV function. So they basically look at pericardial effusions. You can see it very well usually from those views. You can look at VSR, as you showed elegantly in your demonstration here. You can look at mitral valve papillary muscle rupture regurgitation. You can look at our right ventricular function. So all these things can be seen quite readily with a subcostal or subdiaphragmatic echocardiogram. So this is the first question. The second question, Venu, is we have empowered our fellows, and they have a machine always in the unit. So they use it, and they use it very aggressively. Now the question I have for you is, when do you accelerate in an unexplained situation? When do you escalate the treatment to a transphageal echo rather than just a surface echo? And how do you triage that?
So I think you bring up some really important points. While clearly transthoracic echo is the ideal thing to do, but it does have some limitations, like you said, because remember, these patients who are in the ICU are often ventilated. They are very, very sick. And so their acoustic windows are extremely poor. They're also hemodynamically compromised. So you know that they're hypotensive, they're tachycardic, And so our color frame rates and the equalization of pressure between chambers is insensitive to color sometimes. So we always tell our fellows to move very quickly onto a TEE whenever they suspect a mechanical complication, especially mitral regurgitation, and they're uncertain of the etiology. So anytime you see an eccentric jet, either eccentric AI in someone with a dissection, or an eccentric MR in someone with an inferior wall myocardial infarction, and you suspect, wow, this might be a papillary muscle rupture, we should say, go ahead and do a TEE. The other condition where I think it's really useful is in the post-operative state when you get localized tamponade. So if you see a patient who's hypotensive, the RV is not collapsed, yet they're hypotensive, they've just had surgery, who knows, there's a little bit of blood clot behind the left atrium that's compressing the left atrium. There's no way you can diagnose that unless you very quickly do a TEE. So I think the second lesson is not only should you have skills in bedside echo, everyone working in the ICU should be able to very quickly do a TEE or have help to get someone in there to do a TEE. And so if you cannot explain the hemodynamic deterioration on transthoracic echo, I think you should very quickly move to a TEE to try to explain why the patient is in extremis.
So we all as physicians, Venu, thank you so much. We all as physicians learn, actually, that's what we call practice, learn from experience. I remember as a young attending here at the Cleveland Clinic many, many years ago, I got called about 1 or 2 in the morning for post-op evaluation with the TEE. And of course, I was cynical and I said, why they're calling me? We don't see anything on the echo. I looked at the echo, everything was fine. I did the TE at the urgence, was urged by the surgeon to do it just to make sure everything's fine. And despite my training here as, in advanced imaging with echo, I have not seen a post-op tamponade involving only the right atrium. So I put the probe down and we couldn't see the right atrium. So completely localized focal tamponade of the right atrium, preventing filling of the right ventricle and therefore shock. So the patient, of course, went to the OR and did very well. And I learned that lesson from then. Post-op is a very important lesson to know that you can have very localized tamponade because of the adhesions, because the way the blood is sequestered around the heart. So you can have very focal tamponade. Sometimes you can see it of the SVC, of the IVC, of the right atrium, and so on and so forth. So just be careful with that. Thank you, Venu, so much. We took a lot of your time. I know you're a very busy man, and we'll have you very soon again to discuss some other cases with us. Thank you.
This was really fun, Weil. Thanks for the opportunity. Bye.
Cheers.
Cheers.